Hi, students. So let's go ahead and review some of the most frequently missed questions from the final for the last few terms. Okay, so before we go sort of module by some tricky questions, I want to give you just a couple general tips for the final. First things first, we talk about this all the time in class, but please, please, please use clues in the terms themselves to help you with the final. So, for example, we've talked about how the word diabetes means increased urination. But remember, there's two totally different diseases that have the words diabetes in them. There's diabetes insipidus and diabetes mellitus. The words themselves give you a hint. Diabetes insipidus is tasteless urine. Diabetes mellitus is sweet urine. Insipidus means tasteless, mellitus means sweet. That gives you a reminder of what happens in those diseases. In diabetes insipidus, you have excess um, urination and it's really dilute urine. And so that's what's causing that excess urination. That's caused by a decrease in the amount of ADH that's produced by the body. That's a totally different type of diabetes from diabetes mellitus. In diabetes mellitus, the urine is sweet because of the high blood glucose, which results in high glucose in the urine. So once again, using the terms themselves gives you a clue and a reminder about those diseases. So please, 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 as you are doing the final, make sure you are really closely looking at some of those vocab terms and using that to give you hints. Another important tip for the final is please read the questions so carefully. And I say that because you have a plenty of time. You have 2 hours for the final, and I would say in general, most students finish within an hour. So you're not going to be pressed for time. So that means you really have time to like slow down, take a breath, and really carefully read. And what I mean by that is for example, sometimes I might see questions where it will say like an increase in something or a decrease in something. Make sure you're reading that question really carefully so you're noticing if it says increase or decrease. Because I notice sometimes students might get hung up on the whatever the something is. So, for example, going back to diabetes mellitus, like an increase in blood glucose. Students might see blood glucose and then automatically think, oh, diabetes mellitus, but they might have missed the word before that. And if the question said a decrease in blood glucose, well, that would not be a sign of diabetes mellitus. So make sure you're just reading really carefully, especially those kinds of terms like increase or decrease, to make sure that it's not something that's going to trip you up. But that being said, my third tip is remember um, don't overthink. So there's not really any trick questions. Like we're not trying to trick you into thinking of a different answer. It's more just like slowing down and reading carefully. So there's never going to be anything that's like purposely trying to trip you up. It's more just did you really take a beat and make sure you fully read that question and understand it. So, just some general tips for the final. Like I said, use the clues in the terms, really carefully read those questions, and then don't overthink things. There's no trick questions. Oftentimes, the right answer is the most obvious answer. So, trust yourself. Okay, so with that in mind, let's go ahead and go over some of the most frequently missed questions from the final. Of course, I can't just like show you the questions because that would be cheating. But I'm going to kind of go through some of the concepts that you need to understand in order to do well on the 10 most frequently missed questions from the final. And this is from the past couple terms in pathophysiology. So, the first, let's start with module 4. So, module 4, as you remember, is musculoskeletal diseases, so diseases involving the bones and the muscles. So, in this module, there are a lot of important vocab terms, especially like prefixes and suffixes. And remember, this is how you use the terms themselves to give you clues. So, knowing these prefixes and suffixes is really important because it gives you those clues. So, some of the ones from module 4 are things like osteo, that means bone, myo, that means muscle, and then rheuma is kind of this funky prefix. Essentially, that means inflammation of the joints, muscles, and bones. It's kind of like a catch-all term that kind of encompasses a lot of the things for module 4. So joints, muscles, and bones. And then some suffixes. Itis, as we know, means inflammation or an infection, and then penia means a decrease. So we can take some of those prefixes and suffixes and then mix and match them together. And just from knowing those prefixes and suffixes, we can make a really smart, educated guess about specific diseases. So, for example, osteopenia. Osteo is bone, and penia is deficiency. So it'd be like a bone deficiency. In other words, you can't like lose the total number of bones you have, right? So when we say a bone deficiency, that's a deficiency in the cells that are producing those bones and actually making bones. In other words, that's low bone density. So osteopenia is essentially a precursor to osteoporosis. Another example, myoitis. So myositis is muscle inflammation. So once again, we're using the clues in those prefixes and suffixes to figure out what that means. Rheumatologist. So rheuma, joints, muscles, and bones, and then ologist is the study of, so to be a doctor that's specializing in inflammatory disorders of the joints, muscles, and bones. So like I said, we're going to use those clues in the vocab terms to help us figure out a lot of different diseases and disorders. Important to remember, especially for this unit. Okay, another thing that's important to remember for this unit is a lot of the diseases and disorders have to do with age-related changes in bones and joints. Um, so a lot of the risk factors for the diseases and disorders in this unit have to do with advanced age. In other words, as you get older, your risk of getting these diseases increases. And that's just because you're using your bones and your joints every single day. And so over time, the likelihood that something's going to go wrong or they're just kind of like wear out increases, right? This makes a lot of intuitive sense. Of course, also as you age and you live through life more, you're more likely to have some sort of injury. Injuries also can increase the risk of some of these age-related changes in your bones and in your joints, as well as hormonal changes, especially in women. So things like menopause can really have a significant effect on your bones and your joints. So the two main age-related changes here in bones and joints would be osteoarthritis and osteoporosis. Sorry, and I just realized that this picture has a typo on it. Let's say osteoporosis. So osteoporosis would be bone loss. And once again, this is usually associated with age. This is more severe than osteopenia. So osteopenia is low bone density. Osteoporosis would be like it has really, really become very severe, that decrease in the bone density. And then, of course, the other disease or disorder that has to do with age-related changes would be osteoarthritis. This is inflammation, usually associated with age and use, inflammation within your joints. So this is caused by decrease in cartilage in those joints. So let's look at these two diseases in a little bit more specific. But as you were thinking about these specifically two age-related diseases, it's good to keep in mind that the best prevention for both of these, or sorry, the best treatment for both of these is prevention. So of course, as you get older, just the risk of getting these age-related diseases increases. But there's things we can do throughout our life to decrease the risk of those things happening. So that's important to keep in mind as we're talking about these diseases. Okay, so let's start with osteoporosis. So once again, looking at the name of the disease itself to give us hints, osteo means bone, and then a pore is a hole. So osteoporosis, it's bone holes, literally more holes in your bone. So here's a picture of the trabecular matrix of bone. So that's like the center part of the bone that looks kind of spongy, but it's very dense. Or it's very firm. So it's not actually squishy. It just looks kind of like a sponge. So healthy bone has some holes in it. That's just how bone is made. That's normal. Osteopenia, we start to see more of those holes, so the holes are increasing. And then in osteoporosis, you really see a really significant increase in the size of those holes. And that's why it's called osteoporosis, because we can see there's more of those little holes. So how that happens is essentially your bones are always having this careful balance between bone reabsorption, so like bone breakdown and bone growth. So in osteoporosis, the bone reabsorption outpaces bone growth. So essentially your body is breaking down the bone faster than it's able to make bone. Some signs and symptoms of osteoporosis. Of course, osteopenia, like I said, that is decreased bone density. That is like a precursor to osteoporosis. So in osteoporosis, you have sort of marked osteopenia. Generally, you don't really note, or most people aren't generally diagnosed with osteoporosis until they have some sort of fracture that makes a clinician concerned that they might have osteoporosis. In addition, some other things you might see would be shortened height, literally because of like compression of the spinal bones, as well as kyphosis, which is a hunched back. Same thing, those compression of those spinal bones kind of causes hunching to form. That's different than bad posture. It's different than like a buffalo hump that we talk with Cushing's disease. So literally the spine has kind of compressed so much that it has changed its shape. So with these age-related changes in bone and joints, like I mentioned, the best treatment is prevention. So for osteoporosis, the way that we can prevent osteoporosis from occurring is by thinking about that balance between bone resorption and bone building and making sure we're keeping that nice and regulated. So one of the best ways to prevent that is through maintaining a healthy weight and then also by participating in weight-bearing exercises throughout life. So weight-bearing exercise helps promote bone growth and so that really helps keep your bones healthy and prevent osteoporosis. I want to emphasize that as prevention. For someone who actually has osteoporosis, participating in weight bearing exercise could be dangerous because if your bones are already quite brittle and thin, then if you go to like do some very intense weightlifting, that could potentially put you at risk. So, this is more of a preventative to prevent osteoporosis from happening. And then, of course, calcium and vitamin D supplements, those also help keep your bones healthy and help with bone growth. Okay, so then the next age-related condition that has to do with bones or joints is osteoarthritis, also known as OA. There's another type of arthritis that we talked about a little bit in this module, which is rheumatoid arthritis. So rheumatoid arthritis is more of an autoimmune disease. It is not associated with age. So one of the ways that you can remember the difference between these two is that OA for osteoarthritis is for old arthritis, meaning it's caused by old age. Whereas RA, rheumatoid arthritis, is random arthritis. It's not due to age, it just happens randomly to people when they have this autoimmune disease. So, osteoarthritis, old arthritis. So, what happens in osteoarthritis? You have essentially degeneration of the cartilage within joints. So, a normal joint has a layer of cartilage as well as other fluids that helps prevent the bones from rubbing directly against each other. Over time, some of that cartilage starts to go away, and then you're going to have more of the bones rubbing, and that can cause all these changes within the bones around the joints. Some of those changes include things like osteophytes. So these are essentially bone spurs. These form at the edges or the margins of a joint. Some other things you can see are swelling within the joints, especially within the hands. There are special names for those swellings. We have Bouchard nodes and Herbidian nodes. Those are just different names for swellings within specifically the finger joints of the hands that you see with osteoarthritis. Some other unique signs and symptoms of OA. This is going to be joint pain that is worse in the cold and also worse in bad weather. That is because both of those things kind of increase the like friction that is occurring within that joint, so it's just going to make it more painful. That is different than rheumatoid arthritis. And rheumatoid arthritis, generally, someone will feel a little bit better if they start moving and kind of like get things going. It'll increase the kind of lubrication in their joints and make them actually feel a little bit better. But someone who has osteoarthritis, the more that they move, the more that those joints are going to hurt. In osteoarthritis, your joint pain actually gets worse with activity, and then also with bad weather. I feel like there's kind of a trope of an old person who's like, "Oh, I can tell it's going to rain because my hip hurts," or something like that. And that's like an indication of, "Oh, I have arthritis in my hip, and because the weather is bad, it actually hurts more." And that's actually true. That does actually happen. So for me, I can remember that sort of trope, and it makes sense in my brain. So I hope that that makes sense to you too. And then, like I said before, of course, the best treatment for these diseases of advanced age is prevention. So, for osteoarthritis, the preventative measures that a patient can do are, of course, maintain a healthy weight because that decreases the just stress on the joints over time. Exercise, just keeping joints moving. There is some interesting data about should that exercise be high impact or not. So, there might be maybe like a U-shaped curve, especially with something like running and like really long distance running. So someone who is running like marathons all the time, they're putting a lot of stress on their joints as they're repeatedly running miles and miles and miles and miles. And so there's the idea that maybe if you're running like, 3 marathons a year and you're constantly training and running, tens of miles a day, that maybe that's too much on your joints that actually could put you at risk for developing osteoarthritis. And then, of course, if you a patient who's like not doing any exercise at all, then their joints aren't getting normal movement, and so that's also going to put their joints more at risk for developing osteoarthritis. So there's kind of like a medium happy in between level where doing some activity, of course, is going to keep your joints healthy, but maybe doing like too much could be dangerous for them. In general, though, I think most doctors would say exercise is good and don't worry about like exercising too much. There's not many people who fall into that category. Um, but of course, I think another big thing is avoiding joint injuries. This is especially true in like teenagers. So just really helping teenagers make sure they're exercising their muscles and like exercising specifically for joint stability and avoiding things like knee injuries in teenagers because that can lead to joint issues later in life that can kind of follow them all throughout life. So once again, prevention is the best treatment for both osteoporosis and osteoarthritis. And for both of those things, engaging in healthy exercise throughout lifetime is really beneficial. Okay, so that moves us on to Module 5. So let's go over some of the tricky concepts from Module 5. This is gastrointestinal diseases. So one of the tricky concepts from this module has to do with testing for peptic ulcer disease. So remember, peptic ulcer disease is essentially sores that form in the stomach. The stomach is very acidic. So once those sores form, then you're going to have stomach acid essentially burning the lining of the stomach. That's obviously going to be very painful, cause damage to the stomach, and cause bleeding, things like that. Interestingly, most cases of peptic ulcer disease are caused by a specific bacterial infection by a bacteria called H. pylori. And it turns out the way that this bacterium, H. pylori, can live in the stomach, even though the stomach is very acidic, is because this bacteria makes an enzyme called urease. And this enzyme can actually neutralize stomach acid. So, knowing that, we can test for H. pylori infection by looking at, well, one, just do they have H. pylori antigens? Does the patient have H. pylori antigens or antibodies against H. pylori? Or you can also look if the patient has that urease enzyme. So that takes us to the 3 tests for H. pylori. The stool antigen test, which is literally taking feces from the patient and then seeing if they have antigens, meaning like little protein pieces from the bacterium itself. If you have antigens from the bacterium in your stool, well, the bacteria must be somewhere in your GI system. So that's a very good indication of H. pylori infection. The downside of that is some patients are not super comfortable with a stool test. You can do it in like it's almost like a COVID test where you can like dip a little dipstick into a tube, but you still have to collect stool for that. So it's not always something that's everyone's first choice. A less sort of invasive option is a blood test. So that blood test can test for antibodies against the bacterium. That doesn't necessarily tell you that there is an active H. pylori infection, though. It can just tell you if a patient has had a previous infection. So it's a good option, but it can kind of give you a false positive because the patient could test positive for the antibodies, but actually not have a current active infection. And in that case, you wouldn't necessarily want to give that patient antibiotics because they might not currently have an infection. And then another option is something called the urea breath test. So this has to do with this idea that once again, this bacteria can make this enzyme called urease, which essentially breaks down urea to make a base, and then that base neutralizes stomach acid. So in the urea breath test, you can give the patient a radioactively labeled urea, and then you can see if they have that urease enzyme, there's going to be more breakdown of that urea. So then when the patient, you can have them breathe out, and then when they breathe out, some of the carbon dioxide they breathe out will be radioactive because it's been broken down by that urease enzyme. So 3 different tests for peptic ulcer disease. Once again, they're all testing for presence of that H. pylori infection, which is important because it's a bacterial infection. So if the patient has that, you're going to want to treat them with antibiotics, but we don't want to give antibiotics if they don't have the infection. So that's why you always want to test for it first. Once again, there's 3 different types of tests: a stool antigen test, an antibody blood test, and the urea breath test. Okay. So the next tricky question for Module 5 has to do with diverticulitis. So diverticulitis is inflammation of diverticula. So what are diverticula? These are essentially weakening in the bowel wall that causes like these little pockets to form, and then intestinal contents and feces can get stuck in those pockets. So if the sort of stuck material in those pockets gets inflamed, then that's called diverticulitis. Um, so how does this happen? The most common cause is a low fiber diet. So fiber just helps things keep moving through the colon or through the large intestine. A diet that's low in fiber, things are just not going to move as quickly. So you're going to have like more pressure put on the large intestine, and that makes it more likely that essentially at some point you might have a pocket form that's going to be a diverticula, and then that diverticula could get inflamed, and that could cause diverticulitis. And the problem with diverticulitis is because this is inflamed, it actually can cause like swelling around that diverticula. And if it's big enough, that it could actually cause sort of like a blockage to occur. So you can have bowel obstruction as a serious complication of diverticulitis. Okay. So with that, let's move on to Module 6. So Module 6 was a lot of different diseases and disorders. We had endocrine diseases, including diabetes mellitus, as well as some neurological diseases like stroke and neurodegenerative diseases. So some of the tricky questions from this module, there was really only one, and that had to do with multiple sclerosis. So remember, multiple sclerosis is an example of a neurodegenerative disease, and it's progressive. So that means that the degeneration of neurons, so the destruction of neurons, is actually getting worse over time. That's what progressive means. So how that happens in multiple sclerosis is what's actually like damaging the neurons is myelin, which is the insulation and sort of like the protective coating around neurons. That myelin is getting destroyed. And since it's the protective coating, if the myelin goes away, then the neurons themselves can actually get damaged. So you have degeneration of myelin, and then that can cause loss of neurons. And something with multiple sclerosis is specifically that degeneration of myelin is within the central nervous system. I mean, it's just within the brain and the spinal cord. So in general, nerves being affected are not your peripheral nerves, so the nerves going from your spinal cord to your muscles. It's actually the nerves like in the control center, so in the brain and in the spinal cord. That also explains why the signs and symptoms of multiple sclerosis are so varied, because you can really affect any any neurons within your brain. That means you can really affect any organ system. So what's going to happen is the signs and symptoms are going to be dependent on where in the central nervous system that myelin is lost. So you can see some common signs and symptoms like vision impairments due to loss of myelin within the optic nerve. You can have balance impairments due to loss of myelin within motor coordination systems, as well as a number of other signs and symptoms. Once again, all related to wherever that myelin is lost within the central nervous system. Okay, and that takes us to the last module that's going to be on the final, which is Module 7. So Module 7 was renal diseases, urinary diseases, and reproductive disorders. So the first tricky concept from this module has to do with renal calculi. So renal calculi is just another name for kidney stones. So kidney stones, also known as nephrolithiasis, are just like mineral deposits that can form within the kidneys or get stuck within the ureters. So the reason that sometimes they're called renal calculi is because many kidney stones are made of calcium. So calculi, like calcium. So there's sort of a connection here between the renal stones or the kidney stones and calcium. So someone who has a lot of calcium in their body, a lot of calcium in their urine, is most likely going to be more at risk for developing kidney stones because most kidney stones are made of calcium. So keeping that in mind, some of the most common causes of renal calculi, meaning kidney stones, osteoporosis can actually increase the risk of kidney stones. And the idea here is that because in osteoporosis you have increased bone resorption, it's actually like taking calcium that should be in your bones and releasing it into the bloodstream. And so that calcium within the blood is going to go into the urine when the kidneys are filtering the urine. So you're going to have increased calcium within the urine, and then that's going to increase the risk of forming calcium-containing kidney stones. So high calcium in the urine, like I said, in addition to just not drinking enough water, that's going to essentially increase the calcium of anything within, or increase the concentration of anything within the urine, including calcium. Because if you don't have enough water, then essentially you're just concentrating everything in there. So it's going to increase the risk of kidney stones. So definitely make sure you're drinking enough water. That being said, if you're like, oh my gosh, high calcium in the urine, should I not be taking like a calcium supplement? There's not great data that taking calcium supplements are going to increase your risk of kidney stones in most people with normal kidney function. So if you have normal kidney function, absolutely keep taking your calcium supplement. It's probably more beneficial for preventing things like osteoporosis than it is for potentially increasing your risk of kidney stones. In addition, keep in mind that preventing osteoporosis itself can contribute to kidney stones. So to prevent osteoporosis, you're actually also potentially like protecting your kidneys. So that being said, prevention is the best treatment. So keep taking your calcium supplement and then also keep doing those like weight bearing exercises and things like that to keep your bones healthy. Okay, so that was tricky concept number 1 for module 7, which also kind of like ties into some stuff from module 4. And then another tricky concept from module 7 has to do with end-stage renal disease, otherwise known as like kidney failure. This is essentially when the kidneys are just not able to do their job properly, so they're not able to properly filter the blood and make urine. So remember, one of the main jobs of the kidney is to filter blood and get rid of nitrogenous waste. So nitrogenous waste includes things like ammonia and urea, and these molecules are especially toxic to the body, and that's why the kidneys need to remove them and then put them in the urine so you can get them out of your body. Remember also that these substances, ammonia and urea, are natural things that our body makes when we break down proteins. So we really need our kidneys there to help remove that waste that's produced when we break down proteins. That breakdown of proteins occurs whenever we eat protein in our diet, or also if like our body is breaking down other proteins in our body for other reasons. Either way, whatever the reason is or whatever the source of that protein is, whenever a protein is broken down, it is going to make some of the nitrogenous waste, and we will need our kidneys to remove that nitrogenous waste from our body so that it doesn't build up and cause toxicity. So because of that, sometimes patients who have end-stage renal disease are put on a special diet. Sometimes this diet is called like a dialysis diet. This is sort of like a kidney-friendly diet. It's just making things a little bit easier on the kidneys by removing some things in the diet so that the kidneys don't need to filter them. So that could include specific electrolytes like potassium, just avoiding some of those really potassium-heavy foods, or like sodium. Just once again, because like the kidneys aren't working very well, so we don't really want to depend on them to get rid of some of those extra electrolytes. Similarly, you can also eat a low protein diet. This is very common in a dialysis diet because someone who has end-stage renal disease, their body's going to really struggle to get rid of that nitrogenous waste. Where does the nitrogenous waste come from? It comes from breakdown of proteins. So if the patient's eating less protein, then that means they're going to have less of that waste in their body, and then it's going to be more sort of acceptable if their kidneys aren't quite picking up the slack because there's going to be less waste to get rid of in the first place. So that's why a lot of patients who have end-stage renal disease and are on dialysis are on a low protein diet. Okay, and then the last tricky concept from Module 7 has to do with incontinence. Incontinence is essentially, or specifically urinary continence, I'm sorry. So this is essentially urinating unintentionally when you don't mean to. So there's many different types of urinary incontinence, but I wanted to go through 2 specific types you need to know for the final. And once again, the names can give you a hint about what happens in these types of incontinence. So the first is stress incontinence. So in this case, we're talking about stress on the bladder. So if you literally squeeze the bladder, it's going to like squeeze some urine out when you don't intend for it to come out. So this is the most common cause of incontinence. If you've ever, or maybe if you've ever had kids and then you, after recently having kids, you like sneeze and a little pee comes out, that is an example of stress incontinence. And that happens because the muscles that help control the bladder get weaker because of pregnancy, because of the pressure that pregnancy puts on those muscles that actually makes them weaken. And then, of course, you can do things like pelvic PT, pelvic therapy PT, to help strengthen those muscles over time. So stress incontinence is the most common cause of incontinence, like I said, and that's just because of excess stress, like excess pressure on the bladder that just kind of squeezes extra urine out when you don't mean for it to. So that is different than something like functional incontinence. So I like this picture here because it really helps you see the different types of stress incontinence. You can see pressure on the bladder, and the bladder just goes, ah, and a little pee comes out. Functional incontinence, we have a picture of an older gentleman here. So why? So functional incontinence is because someone has the ability to regulate their bladder, but they just can't to get to the bathroom quickly enough. Um, this could happen to anyone. I always think of my classic example is if you're on like a long road trip. I was on one recently and I was trying to think like, okay, are we going to stop so I can go to the bathroom or can I make it to the next exit? If you decided I'm going to try to make it to the next exit and you didn't make it, that would be an example of functional incontinence. In other words, you peed your pants because you just couldn't hold it anymore. In reality, most of the people who suffer from functional incontinence are more likely to be older patients who just have less, just like muscular tone to help control their bladder. And this might be like something like it just takes them longer to kind of get up and make their way to the bathroom at night. And so, because it might take them, 5 minutes to get to the bathroom, they just might not make it in time. So some things you can do to help those patients would be to talk about the importance of like mobility aids, talk about the importance of making sure there's a clear pathway to the bathroom so that they're able to get there quickly. And that's sort of the way that you would treat functional incontinence. Once again, prevention of the problem. Okay, so um, like I mentioned, one of the most common causes there would be impaired mobility, like in someone who is elderly. Okay, and those are our Oh, one last one I like. So the last tricky question from Module 7 has to do with pre-renal disease. Remember, there's three different types of kidney dysfunction. We can have pre-renal dysfunction, intrarenal dysfunction, or post-renal dysfunction. And all this has to do with how the kidneys filter blood. So first, blood goes into the kidneys, then the kidneys filter that blood and make urine, and then the urine leaves the kidneys. That means we can have three places where things go wrong. So the first option is pre-renal disease, which is the problem is the blood going into the kidneys themselves. So usually this is because there's inadequate perfusion of the kidneys, just meaning the kidneys are not getting enough blood pumped into them in order to actually filter the blood. This picture is kind of trying to show you this. So a normal kidney is going to look nice and red because it has a lot of blood getting pumped into that kidney and keeping it. In my mind, I almost imagine the kidney is like plump because it's so full of blood. If you compared that, this is very drastic, but compare that to a kidney that has pre-renal dysfunction, the kidney itself kind of looks a little deflated. It's not quite as plump with blood. And then it's also no longer red because it's just not getting enough perfusion. It's not getting enough blood into that tissue. So, in other words, the kidney can't actually filter the blood if it's not getting enough blood going to the kidney. So, that is one of the causes of kidney disease, pre-renal dysfunction. What is the most common type of pre-renal dysfunction? That would be heart failure. So going back to module 3, when we talked about heart failure, specifically, this would be like a forward effect of left ventricular heart failure. In addition, another potential cause of pre-renal disease would be something like hypotension. In other words, incredibly low blood pressure. That would also decrease the ability of the kidneys to be adequately perfused, so then they couldn't do their job. Okay, so with that, we went through all of the tricky questions. These were the top 10 most missed questions from the last few terms. So I hope this helped you learn some things about some of these specific tricky questions, and now you will do very well on all of those questions that have historically been kind of hard. Um, so as you are studying for the final, please remember to keep in mind, use the study resources that I provide. You can find those in the helpful links for Patho website. I've also posted them in the assignments tab on Canvas and then also in the announcements. So make sure you are using those resources. That includes like the flashcards that I passed out in class, an answer key to the study guide for the final, quizzes, which is signs and symptoms for every week, a Quizlet set, and a Blooket set for vocab for every week. So lots and lots and lots of different resources you can use to study. Remember, you should also be studying a little bit every single day leading up to the final. Don't just say like wait until the day before. I promise you a little bit every day is going to help so much more than just trying to cram it all in the night before. And then of course, use a variety of study resources. Don't just use the Quizlet or something that's not going to do it. You want to use a little bit of everything to really get a holistic approach to your studying. That also helps kind of keep your brain agile and prevent you from just like memorizing the wording in some of those questions. Okay. And then, of course, if you have any questions as you are studying, you can always send me an email. I'm happy to help. And best of luck as you are studying for the final.